Very good. Shika Munka is asking, where is the note set? Just to know, they are about to upload it into the Google Play Store, the UMedico app with the new update of the notes. I just felt that there should be a feature to swap the slides, not only scroll the slides and bookmark them. There should be, once the slide is opened, I want them to swap it. I just now argued with my developers in the below floor, and they're once more quickly doing it. Most likely tonight or by tomorrow, you have the fully pregnant with the notes. The UMedico app will be available. The update will be available for you on the Android Play Store. iOS will take about another 4-5 days before Apple approves the new version, right? So you'll get all the notes. Around 57,000 slides are made available in the notes which got uploaded, right? Now, presence of the hemiplegia with the homonymous hemianopia with the gaze to the same side as the lesion is a typical feature in the case of the middle cerebral artery stroke, is what you have to basically remember. Sandeep is saying, sir, talk about the circle of Willis. Already in the last session, I think Sandeep has missed in the last session, but still I will re-explain you quickly for you to understand, because the stroke, circle of Willis, circulation, there's always a dirty topic unless you are sure you are not able to make it. So you have the two vertebral arteries combined to form the basilar artery, from which comes the posterior cerebral artery. Meanwhile, internal carotid artery will be giving rise to the middle cerebral artery, and also it will be giving rise to the anterior cerebral artery. So the two anterior cerebral arteries are connected by anterior communicating artery, ACOM. And that vessel, which is connecting the posterior cerebral artery with the internal cerebral artery, internal carotid artery, this is called as PCOM. And from the vertebral artery arises the posterior inferior cerebellar artery, and from the basilar artery arise the anterior inferior cerebellar artery, and superior cerebellar artery is what you have to fundamentally remember. So vertebro-basilar circulation, then posterior cerebral arteries, then you have a PCOM which is connected with the internal carotid artery. From there comes the middle cerebral artery and the anterior cerebral artery, and the two anterior cerebral arteries are connected by the ACOM, is what you need to ultimately remember. Right. Now, if you look at the middle cerebral artery, it has got a superior branch. What are the clinical features when the superior branch of the middle cerebral artery get occluded? It all depends upon what areas are affected. Obviously, it leads to a contralateral hemiplegia, that the face and upper limb are more involved than the lower limb. That is, right-sided middle cerebral artery superior branch is affected, means left side facial palsy along with left-sided hemiplegia will come. Contralateral hemisensory loss, conjugate gaze palsy, where the eye will be looking towards the lesion, which is on the right side, for example, then it is right. Then, if it is a left-sided middle cerebral artery, which is left lobe is a dominant lobe of the brain in a right-handed people. Most of the people are all right-handed. So, in the right-handed people, when the dominant hemisphere is affected, then typically you have, that is the left side of the lobe is affected. Then you get the Broca's dysphasia, where ability to express get affected, is what you have to fundamentally remember. Cerebral infarct is earliest detected by which important investigation was the question of the examiner. So you should be sure diffusion weighted MRI, even before the regular MRI, is able to detect, can be able to detect the presence of the infarction. So this is the typical diffusion weighted MRI where you can see the presence of the diffusion defects because of a decreased perfusion, which is leading to the development of the infarction of the brain, is what I want to underscore to all of you. And where is this diffusion weighted MRI is very, very important, especially when you have to take a call. Shall I thrombolyze or not thrombolyze? Where CT is not showing anything, you should be doubly sure that there is an infarct. In all such borderline scenarios, for you to take a therapeutic decision, you need a more sensitive test which can detect the infarction, and that would be the diffusion weighted imaging is what you have to fundamentally remember. Now, doctor, a hypertensive patient, severe headache with vomiting, he got neck stiffness, no focal neurological deficit. What is the diagnosis? What is a very important clue in this question that made you to think that this is subarachnoid hemorrhage? Number one is headache. Second is neck stiffness. No focal neurological deficit. That is the most important clue to say that it is subarachnoid hemorrhage is what you need to basically remember. Now let us talk a bit about this funda of what is this focal neurological deficit. Already we discussed this question in the last session. You have the calvarium. Below that you are having the dura. Below that you have arachnoid. Below that you have the brain, which is tightly snugged by the pia mater. Pia mater is almost snugging it. Where is the subarachnoid hemorrhage located? It is located between the pia and the arachnoid. The bleed is located. So typically, the blood vessels which are supplying the brain, middle cerebral artery or anything, has to pass through the subarachnoid space to enter into the brain. That is, enter through the pia, they enter into the brain. So, if there is a bleed outside the pia, it should not cause any paralysis or a focal neurological deficit. When will paralysis occur? Inside the brain, intracerebrally, if there is any bleed, that lead to development of hemiplegia. So here the bleed is outside the pia below the arachnoid, so patient should not have any focal neurological deficits. But sometimes this bleed will irritate this blood vessel, and that lead to vasospasm, and that vasospasm will then lead to development of hypoxia and focal neurological deficits. So what is the entire goal of subarachnoid hemorrhage patient management? It is to prevent the vasospasm. So hydrate the patient very well. Number one. Number two, give nimodipine, like calcium channel antagonist is the way by which you prevent the vasospasm and prevent the focal neurological deficits. Otherwise, FND is not a part of the subarachnoid hemorrhage clinical presentation is what you need to remember.